So, I mean, I can probably only speak to my own experience. So, I think the major time when I interact with primary care doctors is when they detect abnormal blood counts, in particular like elevated red cell count or elevated platelet count, and they're need some guidance as to sort of whether that could be an MPN or not. And so I think obviously the primary care doctor is critical in the diagnosis of MPN, because many times the patients are not symptomatic and it's just an incidental finding on a CBC. And I think it's very important, obviously, to pick up on that and actually to follow up and either refer or send the appropriate diagnostic test to make the diagnosis of MPN. So that would be my first typical interaction with a primary care doctor. And then obviously MPNs are chronic diseases, so patients live with them their entire life. And so I establish relationships with primary care doctors as we follow the patients together. And it's very important that the patients obviously have a good primary care doctor that they see, because many issues come up along the way in terms of risks for thrombosis, in terms of when they need surgeries, infectious risks with some of the treatments. And so it's really a partnership between the MPN physician and the primary care doctor in terms of like the management of the patients in the longer term. And as I said, it's a lifelong management. So that's really a partnership between the MPN physician and the primary care doctor. So the current state of care is, so the majority of what we do is we institute treatments to reduce the risks associated with these diseases, in particular the risks of thromboses or cardiovascular events like MI or stroke. And so that's really the backbone of our therapies. We also have treatments that we institute to help with symptoms, including enlarged spleen in patients with myelofibrosis, or a lot of these systemic symptoms that patients can have, sweats, pruritus, those type of symptoms. And some of our treatments, including the JAK2 inhibitors, appear to enhance survival, so patients live longer with these treatments. I think our deficiencies are that we don't have a really consistent way to cure these diseases, aside from allogeneic stem cell transplantation, which sometimes we use in the context of myelofibrosis, and aside from interferon, which in a minority of patients with polycythemia vera and ET can achieve what we call molecular remission, so where we can no longer detect the mutations that cause the disease. With those two exceptions, we're not curing the diseases, we're managing them in patients in the longer term. And so I think we've gotten a lot better at managing them. We have a better toolbox now. We have more medicines available. We have more options. But ultimately, I think the future has to be moving, closer towards developing treatments that really have disease-modifying activity and ultimately have the ability to eradicate or cure the disease. That's the goal of my research and the goal of lots of research of people who work in the field.